कश्चित् दुःखभाग् भवेत्।
Good afternoon to all the viewers. It's such a pleasure to be here with some eminent faculty which we have here to speak on a very important disease. But before that, let me give you a quick introduction to TRUWELLTH Integrative Health Centers. Um, TRUWELLTH Integrative Health Centers were established with the mission of Sarve Bhavantu Sukhina, Sarve Santu Niramaya, True Wealth of holistic health and happiness for all, to reverse, control, and prevent diseases and augment health by integrating all appropriate scientific, evidence based, personalized nutrition and fitness therapies, functional medicine, and advanced surgical treatments with a holistic wellness approach. This coincides with our Prime Minister's vision of flagship Ayushman Bharat Health and Wellness Centers initiative as well. Integrative healthcare does not mean alternative medicine. At TRUWELLTH, eminent medical doctors, surgeons, personalized nutrition, and fitness experts focus on the patient as a whole to identify and address the root cause and bring about true relief from diseases by combining ancient wisdom with modern science and bringing about a deep collaboration amongst healthcare practitioners from multiple disciplines to create a comprehensive health ecosystem to help patients meet all their health needs, including physical, emotional, and social. Being the founder of TRUWELLTH with 24 years of rich experience across continents, I firmly believe that nutrition can be modern day's most effective and safe therapy in lifestyle and autoimmune diseases, and as well as infectious diseases. With increase in life expectancy, lifestyle changes, and many other factors, we are seeing increased number of Parkinson's cases around us. It's increasing the concern for, of course, the healthcare professionals, but also for the family members and, of course, the main aspect of the patient being the real sufferer. So, on behalf of all of us, I really extend a warm welcome to our esteemed speakers here who are actually very well managing the Parkinson's disease patients and integrative management of the disease and spreading more and more awareness about the disease is key to reducing the disease burden and at the same time curbing its progress and improving quality of life. That is why we are really here with this special episode of on Parkinson's disease, as we recently celebrated on 11th of April the World Parkinson's Day. So, a warm welcome to our speakers here today, and I'm going to take the proud privilege to introduce both these eminent brothers who are fortunately into the same healthcare segment, and which is why I think lucky for us because they are able to integrate so many aspects of these diseases that it makes it more easier for us to be able to address so many of these diseases. And we are really looking forward to both of them giving us such great insights from their experience and expertise. I'll firstly introduce Dr. Deepak Aiwale. He's a senior consultant neurologist for past 2 decades and is attached to Jupiter, Bethany, Hiranandani hospitals in Thane. He started his own first dedicated neurocare center at Solaris Hospital, which is in Thane as well, which is one of its kinds, multiple super specialty surgical as well as medical center equipped with recent innovations. He has treated more than 20,000 patients with various neurological issues, especially Parkinson's disease, stroke, dementia, neuropathy, and epilepsy. He has vast experience of treating autoimmune neurological disorders like multiple sclerosis, demyelinating disorders, myasthenia gravis, GBS, inflammatory myopathies, and such many more complicated diseases. He has many national and international publications to his name, and he's a lifetime member of the World Stroke Organization, Indian Academy of Neurology, Movement Disorders Society of India, and Indian Epilepsy Society. So, a very warm welcome to Dr. Deepak Aiwale. And we, of course, have Dr. Amit Aiwale with us. He's also the director with the Solaris Hospital and is associated as senior visiting neurosurgeon at Bethany, Kaushalya, and Mahavir Jain hospitals in Thane. With advancing training in neurosurgery from CARE Hospital in Hyderabad, he's fellow of the World Federation of Neurological Surgeons, having performed over 1,500 brain surgeries and more than 5,000 spine surgeries. He specialized in stroke, brain tumors, aneurysms, AVMs, head injuries. The list is absolutely really long, various types of spine disorders. And he's also skilled in endoscopic brain surgeries such as pituitary tumors, intraventricular tumors, and third ventriculostomy procedures. At Solaris, he has introduced navigation guided brain and spine surgeries, which is why, like I said, we are lucky that they are Thaniites with us, and so it's absolute pleasure to sort of have them here. Dr. Amit Aiwale has also received first prize in Next Gen Young Neurosurgeons in 2018 in International Neurosurgery Update with the abstract publication. So proud privilege to have both of you here, and I'm of course going to have a lot of questions to begin with, because like you both say that there's so much of so less amount of awareness about this disease in itself, and it's so more the merrier that we will come to know from you today. So I'm going to immediately take a dive at my questions, and Dr. Deepak Aiwale, if you can really help us understand basically what is Parkinson's disease, and why is it so much spoken about so much? I mean, in current times, it's like the last 4-5 years we hear so many people talking about it. Is the rise only because there's more awareness, or is it because there are so many issues that are grappling us? If you can throw light on that.
First of all, thank you for inviting us on your forum. It's a pleasure joining you, and I think you are doing a wonderful job in your field. And it's all about a holistic approach towards any disease. So I think today is our chance to talk about Parkinson's. Now, to start with, what is Parkinson's? So we have been introduced to this term Parkinson's almost for more than 2 centuries now. So our understanding is traveled across these 2 centuries, and today, as we see it, that it is actually not one single disease. It is a group of disorders where you have overlap of various symptoms. So a better term to deal with these disorders would be Parkinsonism. So today, as we look at it, we initially look at Parkinsonism, and then we differentiate after clinical and lab investigations or of our observations that whether it is a typical idiopathic Parkinson's disease, which was actually described 200 years back. So the name for this illness comes from the initially it was described by James Parkinson in 1817, where he noticed patients in their 60s with tremors and slowness. So he labeled them as shaking palsy. So it was tremors and patients could not move fluently. So there was slowness in their movements and there were tremors. Gradually, later, it took another almost almost more than 100 years to understand the pathophysiology on autopsy basis, where we located this illness to some accumulated alpha-synuclein antibodies in brainstem. And then almost another 40-45 years where we could say that this is related to dopamine deficiency. And then almost in 1967, where we noticed concept proof of this idea by having IV levodopa causing a response to these symptoms, where the patient had tremors and slowness. And now in another 50 years or so, we have observed various Parkinson's plus disorders which have to be differentiated from the typical Parkinson's, because they lack response sometimes to the typical medication which is responsive, which causes response to this Parkinson's disease improves with this levodopa and carbidopa. But these Parkinsonian disorders respond variably, and they sometimes have a treatment which is far different from the typical idiopathic Parkinson's disease. So what is Parkinson's disease, which was described almost 200 years back, and what is the broad spectrum of Parkinsonism? So typically these patients are basically having slow movements of their body. So bradykinesia is a common symptom, and along with that, if they have tremors, imbalance and stiffness in the body, that completes the major criteria. And when you rule out other causes which can cause Parkinson-like symptoms like drugs, stroke, any infection or any trauma, then you label it as a typical Parkinson's disease. So this is this slides at present shows there are two types of symptoms. One is physically visible motor related, which is related to movements. These are slow movements, which is called as bradykinesia. Tremors, which are usually seen at the rest, and they are typically improve with movements, but at rest these tremors are there. And when you try to see the movements of limbs passively, even with other person's assistance, they feel rigid or stiff, and there is lack of facial expressions. Sometimes blink rate is less, and often they have a stooped posture. So these are motor symptoms. And non-motor symptoms, which possibly are present almost 15 to 20 years prior to the noticing of motor symptoms, they are usually in the form of some taste and smell disorders, sleep disorders, sometimes vague gastroenterological gastric problems like constipation, and sleep problems usually have in the form of restless leg syndromes or REM, sleep behavior disorders. So I think almost when the patient comes to the doctor's notice, he has had some subtle expression of these symptoms, which we can call it as prodrome of the Parkinson's disease, where he has had these symptoms of sleep and gastrointestinal problems. Also, sometimes mood disorders, depression, anxiety, which has been often going to psychiatrist. And then ultimately, only when he has had some problem with his physical movements or tremors, only then he has been referred to a neurologist. So a lot of time is lost in reporting to a neurologist when by the time they reach us, they are already into moderate to severe kind of Parkinson's illnesses. And with regards to your second question, that is the incidence of Parkinsonism on rise? Yes, definitely, because in last 2 decades, there have been so many advances in our medical treatment that the life expectancy, which was in early 2000, was around 65 to 67 years, now is gone up to 82 to 85 years. And almost the incidence of Parkinsonism doubles that of the 60 years of age at the beyond 80 years of age. So in next 20 years of life, a 60-year person has double the chance of getting Parkinsonism. So I think that is why we are very often frequently seeing Parkinsonism patients in recent times. And that obviously with geriatric population, it is also a responsibility of the family to take care of our senior citizens or elderlies at home. And because it is related to physical movement, and not just physical, it is also related to your moods and behaviors. So definitely it adds to proper awareness about the illness will definitely help to deal with these patients and help them in a better way. I think general population should be more aware about Parkinsonism. Rajashree?
Yeah, absolutely.
Would
So,
you-
I think it's very interesting to know which is an aspect again which is not understood as Parkinsonism. So, it can how to really decipher, first of all, understand that disease itself. So, how important it is to be, so again, a question for you: how important is it for a timely addressal of this disease, and what is the right time a patient should come to you? And nextly, there are immediate obvious questions are like, how early will it progress? How much will it progress? And can this primarily be a reason of fatality, of, death, which is what everyone fears?
Yeah. So basically, as we talked, that it should be an holistic approach. So definitely some of the non-motor symptoms which we say that they are appearing almost a decade or more than a decade prior to the actual motor symptoms. So definitely these have to be kept record of. So any deviation from their normal life. Now, it's not just that elderlies are affected, but the most common presentation is in sixth decade. So by the time this sixth decade is there, they have their kids grown up, and they realize that it's an age where they are about to retire, or they have had some major events in life. So sometimes it is misunderstood that because of some life events, they are going into depression. So actually, it is not a functional derangement where they are going into depression. Actually, it is a pathologic change which is causing them to go into mood fluctuations, anxieties, impulse control disorders, and also lack of interest in their routine hobbies and leisures. Even their appetite or the food habits, they change. Sleep disorders come up. So now, if there is a constellation of symptoms, they have to start noticing about the motor symptoms. These patients do not need treatment for Parkinsonism at this prodromal stage, but obviously they have, for a better quality of life, they have to be treated for these non-motor symptoms as and when noticed, and they have to keep watch with the background that yes, if he has had some associations. Now, there is an interesting association where Parkinson's Movement Disorders Society also includes diabetes mellitus and physical inactivity as a what you can say in calculation of probability of having future Parkinson's disease. So with regards to medications, obviously we do not treat in prodromal phase where they have non-motor symptoms. We treat sleep disorders as it comes. We treat psychiatric symptoms as they come. And if they can have constipation, so functional bowel disorders can be treated accordingly. But then if they are having obesity, they are having physical inactivity, they are having diabetes, and sometimes association has been led to also head injuries in the past. Supposedly you have had any major head injury. So best example was Muhammad Ali. He had been a boxer, and he had a prolific career all through his life. But as he retired, he had gradual deterioration, and such this is called as dementia pugilistica. So here you have Parkinsonian symptoms can be triggered by head injuries, and also that's an interesting protective effect of caffeine consumption. And obviously smoking also had some association where it reduced the risk of developing Parkinsonism. But that having said, I think diabetes, which I think in Indian population, more than 50%, approximately 50% of population has a prevalence of diabetes. Diabetes, if you treat your conventional risk factors well, you have your sugars in control, you put your lifestyle in place by having adequate physical activity, and that physical activity should be at least moderate physical activity, mild walking. No, I think physical activity in diabetes control, if advised to such patients, can be protective or may contribute to slowing of progression into your frank Parkinson's disease. And only when you develop symptoms of tremor, slowness, or imbalance, which is causing him discomfort, only then we start medical and physical rehabilitation. So medical treatment is offered only when it is disturbing activities of daily life, not for anti-Parkinsonian drugs will not work for non-motor symptoms.
Again, a very interesting
yeah.
aspect which you brought up, and of
Yeah.
course was going to be a part of my question if there are other metabolic diseases which are associated with can be risk factors for Parkinson's. So diabetes, which you've evidently told us, and that I think sort of puts a lot of responsibility on our end as nutritionists as well.
I think with your perspective, Rajashree, I think nutrition, now supposedly we are talking about non-motor symptoms, constipation, obviously having high fiber diet, and you can have having vegetables, nuts and fruits in your diet will help with these constipation symptoms, which are very early in your prodromal stage. So I think having a good food habits, having physical activity, and if at all you have diabetes history and proper screening, and if you have diagnosed with diabetes, good control of your blood sugars should prevent you from progress, or at least slow the progression of your Parkinson's disease. Obviously, these are all associations, but not proven. There is no drug as of now which we have been able to provide to our patients which can cause total cure. So we are providing symptomatic relief, and there are so many new what you can say aspects where we can look into. 1 to 2% of Parkinson's patients also have genetic inheritance, or you can say monogenic forms, but they are called as young onset Parkinson's disease predominantly. Even there we have been able to just identify the gene loci. So not that we have been able to give solutions for that, but definitely these insights will help us to develop future therapies where we can have viral vectors used for gene deliveries, and also newer gene therapies. But I think we are still far midway into our journey towards complete resolution of this disease.
So what I understand is that the therapy or the treatment. The medical treatment itself is very new, and we have very few classes of drugs to actually even take care of, or
Yeah.
rather even manage this disease.
So I think we just talked about the non-motor. As we go into motor phase, or the frank symptoms which are causing affecting the daily routine of a patient. So most of the most common presentation is tremor dominant, where there are rest dominance, and the other presentation is postural instability and gait disturbances. So in tremor dominant, obviously we try to give treatment in the form of, first would be a MAO inhibitor. There is salgelin and rasagiline. So these are MAO inhibitors. And these are because of their some mild anti-Parkinsonian effect, and also some effect in preventing oxidative injury, oxidative stress, and free radical injury. They help in early symptoms, slowing of progression of in the early phase of your motor symptoms. And then we have conventional levodopa and carbidopa combinations, where we are giving dopamine supplementation actual to which is given for improving the tremors as well as the motor symptoms. Motor symptoms are more in form of slowness and stiffness and postural instability as well. And sometimes what happens that when it is we have used, not all patients have similar kind of response to levodopa carbidopa. Some have a good control for 10-15 years without any problems, but some have to face some issues like motor fluctuation. So your motor response or response to the drug sometimes become unpredictable, and you have some off periods where, in spite of being on medicines, you have slowness or gait freezing. And in those times, and or sometimes excessive movements because of long-term use of levocarbidopa, which are involuntary excessive movements called as dyskinesias. So this can become troublesome with levodopa carbidopa. But then we have to titrate these drugs slowly while adding to the patient's regimen. We have to titrate slowly, and supposedly if you have to reverse, or you have to lower the doses, even withdrawing suddenly is a problem. So we should be withdrawing the doses gradually, and obviously use combinations to our advantage, where we can offset one drug's side effects by the other drugs. Supposedly you for example, dyskinesias or excessive movements can be well compensated by adding amantadine. So amantadine and rasagiline or salgelin with a levodopa and carbidopa combination can definitely reduce dyskinesias. When you have excessive tremors, there is something called as trihexyphenidyl or benztropine. These can selectively act on tremors, but then again they have problems with regards to hallucinations or mild psychosis, sometimes urinary retention, constipation. So they have to be titrated very slowly in lower doses initially, and then with patient's adaptation, you can increase it higher. In case you face delusions or hallucinations, we add typical antipsychotics or atypical antipsychotics, because typical dopamine blockers can, which are the antipsychotics typically used, they can worsen Parkinsonism. So you use quetiapine and clozapine, which are the newer drugs. And then there is also what you can say for constipation, you use various drugs which are specifically complementary to your anti-Parkinsonian drugs. Bladder symptoms can be used by intravesical botulinum therapy, and then for memory, sometimes in the later stages. So how this Parkinson's progresses, first are your non-motor symptoms, which is affecting the your brainstem area, where medulla could be the area where various nuclei involving non-dopaminergic neurons like serotonin, adenosine, and non-adrenaline. So these cause, as we have mentioned earlier, the sleep and bowel and behavioral disorders. And when dopaminergic drugs in the midbrain, substantia nigra, they are affected, then you develop your motor symptoms. And in the later stages, even the cortical neurons are affected, cholinergic neurons, and you can have mild cognitive impairment and even sometimes psychosis. So as the disease progresses, you keep on adding the symptomatic therapy because there is no cure at all to this illness. So we are identifying the patient at what stage of Parkinson's disease are these patients, and accordingly we give symptomatic therapy. Now, medical therapy alone will not help. So obviously, for your what you can say, the symptoms are related to movement. So you need a neuro rehab part to this. So I would say neuro rehab part is very underrated in the management of any of the disorders, neurological, most of the neurological, but more so when it's very obvious that we are struggling with our movements, that should be practiced enough. So I think physiotherapy for your what you can say mental well-being, psychologist, and these muscles even affect your voice. So hypophonia is one of the problems. Even later, you have moderate to severe degree, you have swallowing problems. So swallowing, speech and swallowing therapy and occupational therapy. So supposedly Parkinson's is such an illness where patient has their his cognition, his or her cognition is quite intact until later into the stages, severe illnesses, until he progresses into the severe stages, he still has his cognitive domains intact. And so more so they would be more affected psychologically because of that restriction. And to deal with this, I think you need a team of experts who can help them. So I think psychologists, nutritionists, speech therapists, and swallowing therapists, and then the ultimate neurophysiotherapist who can give them inputs about balancing and gait training. I think number of repetitions of sessions will help. Training the caretakers to repeat those sessions at home, because I think repeating what you want to learn will help them develop those, you can call it as muscle memory in layman's language. If you practice it without even understanding it, it is going to help you in your development of your balance and gait.
Great. So, I mean, I'm sure we are going to request you to do another session on this because, you have a complete team who does this integrative management. So we would want to, of course, want to learn on every aspect more in detail. So realizing that how complicated this whole thing can get as it progresses is something which patient, caregivers, doctors all together only can, manage it well. And patience and happiness, I think, is the key in this situation as well. Having said that, there are newer devices, technologies coming up in the medical world today. Are there any such devices and technologies that, of course, we will have Dr. Amit Aiwale talk about the surgical side, but, are there any in the regular practice, are there any technologies?
One of the aspects which I think I would like to add on in the neuro rehab part, there are so many electronic gadgets. So occupational therapy. So patient, if he is able to do his daily routine well, at least that adds to his encouragement and motivation to take part in his treatment. So there are so many electronic gadgets like electronic toothbrushes, shaving kits. You have electronic shaving trimmers, and you have now rollator walkers, which can help them to sometimes, at least till moderate stages of Parkinson's disease, to be independent with the help of your walking aids. Then for virtual reality has come into this thing. where you can use virtual reality to train them into your balance and gait training. You can have some tricks like laser beams can be provided in terms of gate freezing. If you have a laser beam, it provides a sensory cue. So the gate freezing can be dealt with in this way. I know, and I think there are and also there are like sensory stimulations. You give somatosensory inputs by giving some stimulating your muscles by there's a you have some bands, and they provide specific frequency for each patient. You find out by trial and error, and that gives a somatosensory input, and your gait freezing can improve. So I think there are wonderful examples of Parkinson's patients who have not been able to approach their cycle, and they have not been able to sit or aboard their cycle. But once they are onto their cycle, they can ride their cycle very spontaneously. So I think it's an involuntary, what you can say, the involuntary procedures can be done sometimes very easily by these Parkinsonian patients. They can very well drive their cars until moderate stages, but as soon as they get off their cars, they freeze, and then they need help. So these are some interesting facts where the caretakers and the patient get aware. They can themselves also give inputs where we can, as a neuro rehab team, prepare, customize some what you can say gadgets or cues for them, which makes them their life easier.
So I believe that also means that we have to keep creating more and more awareness and try to create community groups. So these kind of exchanges can, of course, help us share so many of our learnings.
The most difficult part is there is no single solution. It can be only a customized solution by understanding the whole spectrum of problem in a particular patient. You cannot have a single medicine to give you a single shot under total cure. You cannot have a specific physical therapy. You cannot either have a specific, even I think Dr. Amit would be talking about surgery, but even surgeries are not going to give total cure. You have, it's definitely they add in selected cases, predominant burden of the disease can be reduced. But definitely there is a customization. Every patient is a unique patient. And even in a one particular patient, there are very array of symptoms which have to be dealt separately.
I think that really brings us to Dr. Amit. I mean, if you can sort of, as an expert in neurosurgery, if you could, help us understand what are the different surgical treatments, and how do they play a key role in managing Parkinsonism or Parkinson's disease, and can surgical treatment sort of significantly improve motor symptoms, of course, but in addition help reduce the medication burden and generally improve the quality of life?
So basically, there is a procedure called as deep brain stimulation, which is now newer technology which has added to the armamentarium of neurologist, I would say, not just the neurosurgeon, because few selected cases where the motor symptoms are predominant, like rigidity, tremor, bradykinesia, dyskinesia, these patients we can offer a deep brain stimulation. But deep brain stimulation is a procedure where an electrode is placed into the brain, specifically at nuclei such as subthalamic nucleus and GPI, we call it globus pallidus insipidus, where which is specific for the tremor. In this, we put a electrode with a burr hole into the brain, and it is connected via a subcutaneous wire which runs from your head into the clavicle region. And there is a what you call a pulse generator, a remote control, which actually generates pulses, electrical stimulation, which can be regulated externally. We can adjust according to the patient's need, and with some trial and error, we can control the these tremors and rigidity. So it is done under local anesthesia where patient is not completely anesthetized, and stereotactic frame. This frame is actually based on the mathematics of X, Y, Z axis, where we can calculate with the preoperative MRI with the frame, one more MRI, and then exact localization of the subthalamic nucleus, and then targeting according to the neuronavigation and the stereotactic frame, and then giving this small thin electrode chip into that nucleus. And this is something which is giving absolutely great results nowadays, because the technology is so much advanced, and we can actually see some tremor reduction on operative side, on the operative day in the operation theater. And during the operation, we have the neurologist who is monitoring the symptoms and who is guiding the surgeon whether there definitely this is the right nuclei and there is right response which we can see.
So I think,
but this in these cases the most important point is the patient selection, because there are a lot of things and symptoms which will not be improved, and patients understanding and expectation from the surgery which should be matched. It should not be that patients have very high expectations and their expectations are not met at the end of the surgery. So the motor symptoms, these are very good response, but not the cognitive or the non-motor symptoms. So cognition, postural instability, mood behavior, and autonomic symptoms may not improve with the DPS. And selection criteria, there are different criteria which includes the age and the Parkinson specific to the idiopathic Parkinson's disease, not the Parkinsonism. As Dr. Deepak told, Parkinsonism is something which has a multiple era of symptoms and different variant categories. Then the patients which are levodopa responsive, then off and on disability dyskinesia, disabling motor fluctuations, degree of disability which has to be scored. Then neuropsychology analysis has to be done. Then advanced comorbidities, high risk patients, those are usually contraindicated, and patients who are on long-term anticoagulant blood thinners have higher risk of bleeding during the surgeries. And family counseling, that family should also be understood and they should be involved in the treatment. It's not just the patient, but the family or the caregiver who should be involved in this surgical planning. Yeah. I can't hear you.
You
Yeah.
really, in a nutshell, you really help us understand, Dr. Amit, about, what are what can be the surgical treatments that are available.
Yes.
But when, normally when it comes to anything that is a surgical procedure, the first fear, and especially because there are a lot of senior citizens, there is a fear, natural fear that, will these treatments be safe? And anything having to do with neuro and brain is something which people are worried about. So what's your advice for such patients, that should they be really free of any worry when these procedures are conducted?
See, any surgical procedure definitely involves some risk. So it is not that it is a risk-free, but definitely we have to understand the risk and benefit ratio. When any surgical procedure is advised to a patient, it is considered that it will benefit, and it is a combined team analysis, not just the neurosurgeon, but neurologist, psychologist, the neurophysiotherapist, the radiologist, and a whole team has a common discussion before planning such surgical procedures. And when the collective approach and they feel that this patient will definitely have some improvement, then these patients are offered the surgical care. Also, with the recent advances, the anesthetic care and anesthetist drugs which are there, those have made us do surgery even in the elderly patients. And specifically, as I told you, these surgeries are done not under the general anesthesia. These are done under the local anesthesia. Patient is aware and they are talking and they are moving hands and legs during the surgery, because that is what we have to monitor in these patients. So these surgeries are definitely far better safe compared to what was before 10 years. But but still, I would say there is some understanding which has to be there that no procedure is risk-free.
Well, that's really reassuring to know. I think that surgeries are such a or these procedures that are coming up new are really going to be more amount of relief for when the disease progresses majorly. Are there any more advances in pipeline,
Yes,
Dr.
yes.
Amit?
See, now a lot of research has been going on the stimulator. Pre Previously, we had a wire
I'm
connecting
sorry,
the
may I request you to stop screen sharing so that we can see you better?
Okay.
Sorry.
So basically, now previously we had a wire connected with the stimulator and the pulse generator, but now Wi-Fi has been tried. Newer technologies like ultrasound sonography under navigation and the MRI has been tried for the creating small lesions, that is called as lesionectomy. These are being researched where patient does not have any scar, but ultrasonic radiation or ultrasonic sound waves can just create a lesion at subthalamic nucleus and exactly reproduce those results. So these things are under pipeline, but still it is not into the clinical practice. But DBS, deep brain stimulation with the electrode, is standard right now, and it has been accepted whole worldwide and also in the India.
I think there is also one more aspect that there's a lot of interest in what you can say gut microbiome. So gut microbiota, that is also looked at as one of the source of this pathology of Parkinson's, which is there is a gut barrier and then there is a blood-brain barrier. So in prodrome phase, where we said the patients are affected by gastrointestinal symptoms like constipation, and there is this interface of gut and blood-brain barrier that is affected. Enteral neurons can be affected, and you can have this synuclein pathology travel via vagus nerve to your brainstem, and in that way, now they have come up with role of probiotics in that is one more avenue which is it is thought of. Then almost there are fecal transplants from healthy individuals, fecal transplants into those with prodromal symptoms. That thing is ongoing. Stem cells, fetal pluripotent stem cells have been tried, but it has been it's not been very assuring. But obviously, there's something which we can work upon, and with better studies, I think we are looking at these avenues of treatment.
So yeah, I think since you mentioned the microbiome, yes, there's a lot of research going on in that area. But also another aspect which I keep emphasizing on is improving your digestion overall. So a lot of research needs to happen and is happening also in the field of enzymes. So enzymes are again very critical to if we have a better digestion, obviously the mood is also better because a lot of use of enzymes can actually relieve constipation to a great extent, because normally what happens is we have dilemmas, right? We have these patients, they have other comorbidities. So like you said, diabetes. So what we naturally land up doing is giving them low carb diets, which will be low GI, and then they're going to be high on protein. So what happens is when it's low on carbs, the energy levels are really going to be low. So, the quotient of, again, the balance between the depression and the energy levels. When you talk about proteins, many of them have creatinine issues. So, again, giving high protein, it's more important to give the right quality of protein and the right amino acids that they would get. So, it's a very tough balance that we have to actually manage. So, again, a very important role of integration out there, because integrating it with your medical and surgical treatments, and at the same time giving them a very personalized sort of a plan, which not just talks about nutrition, but also helps counsel them a little, so that while the psychologist is doing, also using food for mood, because food has really that power to sort of help people feel good. So, just having a nice cup of tea at times can actually even elevate their mood, sitting with these patients, talking to them. And so actually trying to make plans which give even the caregivers the instructions that, at this meal, sit at the table, eat with them. All that will just sort of make them feel more positive and again add to, uh, reducing the progression of the disease is what I think. But on the other hand, while we're talking about the surgical treatments, there are some of these videos going viral on the WhatsApp. This is something I want you, Dr. Amit, to address, because then, suddenly people start thinking that there are some magical treatments which are just going to sort of bring them out of the disease. And, if you could help clear that myth, that will be really great.
I think I would like to take up that question, I
Sure.
suppose. We have had this apomorphine infusions. So morphine infusions, usually these are short-acting rescue therapies, and they are usually given to patients who have already been on Syndopa and all other anti-Parkinsonian drugs. Still, we do not have a good motor symptoms resolution, or you have off phenomenons and dyskinesias and motor fluctuations. So I think for off phenomenons, when there is gait freezing or worsening of motor symptoms, for short duration, you can have this apomorphine sublingual patches, or you can have infusions also. But then it is not practical to use infusions long term, and also there is a potential to have abuse of these things. So because you have a better modality who can give you a good control, only a select few patients who have had poor motor control on anti-Parkinsonian should be offered these rescue therapies, and not that, as I said, there is no single treatment modality which can resolve your Parkinsonian symptoms at all, and neither as the time progresses, your symptoms are also changing. So there is not no single remedy to cure it to eradicate the disease. So definitely you cannot rely on any single treatment modality for lifetime of these patients. Rather, as you are talking, if you typically see a patient with Parkinson's disease, it starts affecting his daily activity in the sixth decade, and you have a prodrome period of 15 to 20 years. So by the age of 40, whatever he has accumulated as his physical activities, his dietary habits, his genetics or epigenetic influence, I think that is deciding how what are his chances of developing Parkinson's. So I think early in your life, having a good approach towards lifestyle modification can definitely reduce your chances, even if you're otherwise epigenetic influence or genetic influence is giving you a higher probability of Parkinson's.
Yeah, in DBS also the similar thing. It is not that one particular setting of pulse stimulation will help you throughout the life after the surgery. Even patients with DBS will have to
reprogramming is required.
The regular interval programming of the stimulus will have to be done. The voltage and the frequency of stimulus will have to be depending upon the patient's symptoms, the clinical situation. He has to come for the follow-up and get the settings done on repeated basis. So it is not that once the surgery is done, definitely he is fine for whole life. So this should be understood by the patients.
Great, and I think there are a couple of questions also. Of course, are there times when medical therapies should be avoided? I mean, and are there any diseases where the side effects or anything? There's a question here.
I think avoided should be rather than once you have had, there is a criteria that you should be offered medical treatment only when it is affecting your daily routine. So I think patient himself will be asked, or he is the decision maker, that how frequently he falls. Now, supposedly, we often get patients not because they have chosen to come. Sometimes they come with a fall, head injury. They come with hip fractures, vertebral fractures. And that is the time when a neurologist comes into a picture, that a head injury, a neurosurgeon has seen, feels that it is a Parkinsonism, he's referred to a neurologist. Hip fracture, orthopedician sees, and vertebral fracture
Yeah.
also orthopedician sees, and then they refer that they suspect. So most of the time, it's more so that patients and caretakers delay reporting to the patient that activities have been affected already. And once they have come early, if they have noticed early, but still they usually are coming to the doctor because their daily activities are affected. But if it is always wise to have a discussion, what is the expectation of the patients? It's the improvement of quality of life. There is nothing which we are assuringly able to offer in terms of slowing or curing the disease. So definitely the point is, what is the difficulty in daily routine, and accordingly medicine should be given. If at all somebody says that I have a good movement, supposedly ulta, suppose that patients and caretakers think they do not want to take medicines, but they are suffering from immobility. So immobility has its own problems. If you choose immobility over medications, then I think it is as a health professionals our duty to counsel them that mobility will help to reduce complications. Like you can have your built muscle, body muscle mass and bone health is dependent on mobility. Your mental health is dependent on mobility. Your chest infections, if you're having immobile vocal cords, difficulty with swallowing, your communication, and sometimes even constipation and blood. So I think discussing thoroughly their problems and what can be considered not interfering with life, obviously not to be treated, but something which is affecting daily routine should be offered a treatment, because it is preventing your subsequent complications.
Well, there is one more question on hypothermia, or any changes in body temperature. Is that also expected, that someone can feel hot or chills, or that kind of a.
I think there is autonomic dysfunction also involved in this. So definitely there is autonomic dysfunction can lead to you can have postural hypotensions, your difficulty maintaining blood pressure. So there we have to check for this orthostatic hypotension, where you can have cold extremities and all. And there we offer symptomatic treatment like extra salt supplementation, some mineralocorticoid treatment like fludrocortisone, and some now newer drugs like metodrine and doxydopa. So maintaining BP and subsequently even temperatures.
So a couple of things more now from my end. Of course, one very important thing I would want you to address is stigma again, because this disease has, if we have noticed the last decade, I think we have really started understanding this disease at all, that too few in number. But there's so much stigma around. A lot of patients don't feel like going out. They just decide to be at home. They leave their professional activities. And I think that probably adds to the depression quotient. So how would you actually, either of you,
I had an interesting two patients of mine, and they were like what you can call one friend was having Alzheimer's and other friend was having Parkinson's, and they both would come together to consult. So obviously the Parkinson's patients had his cognition and memory intact, but his movements were affected. And Alzheimer's had a good movement, mobility, and his memory was affected. So obviously they complemented each other. And they had that what you can say interactive friendship or camaraderie where they both complemented each other well. So participation in community participation, giving them more opportunities to come out and have some interactive activities, participate in others' cause also. So you can have forming communities can definitely help. I think
Here I would like to add something that just being old does not mean that you have to lose your memory. You have to have a disturbed memory. You have to have restricted activities. Your gait will be disturbed. Then you have urinary incontinence, bladder incontinence, motion incontinence. So sometimes, as a caregiver or as a younger generation, we tend to say that no, he's old enough. That's why he has this problem. But it is not like that. Some patients who are 90s and still doing all the activities comfortably, and someone who is 65 is not able to do the same thing. So definitely we have to find some cause. Now, there are a lot of neurological disorders, not just the Parkinsonism, which affect the daily activities of the life, and this should be evaluated thoroughly. So there are sometimes variants of Parkinsonism, as Dr. Deepak told. Sometimes I have seen one patient with normal pressure hydrocephalus. In these patients, he was around 84 years and he had memory disturbance, urinary incontinence, and gait disability. But after the proper evaluation, we could do the VP shunt. And after shunt, he was able to have a good balance, memory was improving, and the family was, oh, we were so misunderstood that he's just old and we are not doing anything. And after the surgery, patient had good quality of life. So there are ways which we can find the cause of his disability. And being old is not just that we should leave it alone there. We have to find the cause.
That's really real. Again,
I think you cannot have an excuse of aging for poor quality of life. I think we have now more and more geriatric population, life expectancy increasing. So we have to have a novel approach, or you revise our approach towards aging. You cannot have simplistic explanation of any symptom as aging. You have to get it checked.
So I can't but end the program without asking both of you that it's really a proud feeling that, we have a neurology specific hospital here. And, how did that whole idea come to, birth, and, how are you sort of pursuing it with Solaris, just as the son, of course, so what would you like to share? Because, this is something we would definitely want to know.
I think looking at this example of Parkinson's disease, similarly, life goes this way. You never have what you can say predicted what would happen. It is unpredictable. So, but whatever you do in your early life is going to reflect in your later life. So basically, it is sometimes genetics, then epigenetic influence, and people who we met across our school days, and then recently in our medical fraternity, we got some experiences where we felt that obviously neurology was never a conscious decision, but such a wonderful field that as I passed out from MBBS, then medicine, I was naturally inclined through my journey that this seems to be interesting. And obviously now with more into this field, there are certain shortcomings where we cannot do in other setups. So now we wanted to take the responsibility of making this change ourselves. And with that intent, we have come forward that we would want to bring in whatever is new, whatever is better for the patient care. Like these are the times of precision medicine, precision surgeries. So minimal invasive surgeries, newer monitoring, neuro monitoring, intraoperative neuro monitoring, which reduces the complication rate of surgeries and treatment, and also reduces the hospital stay, and ultimately the cost burden to the patient or our health resources. So I think our vision is to provide more of a precision treatment and reduce the burden of treatment by reducing the hospital stay less and educating also obviously as we talk now better prevention would be a better than a cure. So only those who need treatment for serious consequences should come to the hospital. If you are aware, definitely you can prevent into getting into situations where you require some surgery or a critical treatment.
Dr. Amit, would you want to add anything?
Yes. Just I would like to say that neurosurgery, being a very complex and highly considered very high risk, patients are scared. But during my journey, I have seen that there are a lot of good results and there are wonderful techniques which are possible. Just because of the cost constraint, patients are not able to get that. And by having an individual approach and patient-centric approach, we can actually target the patient according to his needs, his requirements, and tailor-made the treatment options also. Now, as I told you, anesthesia has been such a wonderful improved that we are doing a lot of awake craniotomies where we are actually monitoring patients awake, monitoring their power, motor symptoms, their speech, and removing the tumors, removing the glioma during the surgery. So these patients are definitely getting this kind of treatment now. They don't have to go to the higher corporate hospitals and pay very high amount, but that is feasible at a nursing home kind of hospital, but where they get the advanced treatment and with the personalized care.
I think we wish you all the very best. You're in the best city that you can be to take this initiative forward. And the city has seen a lot of good healthcare initiatives or hospitals which have thought differently and greatly and have achieved great success. And it has really helped the city to cater to the patients very well. So wish you all the very best on that note, and thank you very much both of you for taking our time, because I know it's not easy, and on a Sunday I've really dragged you here to bring about the education for this difficult disease, and I'm of course going to trouble you with more diseases that you can actually share your insights on with us.
Definitely. I feel that everyone is aware about the cardiac heart,
Yes.
because it is a deadly thing. But no one is aware that neurological problems are so severe and they are affecting your daily life, not just the death. It is not about the death or regarding the only mortality, but it is about the morbidity which it brings with the time. And also the treatment which has to be given, it is a long-term treatment. So the cost factor is also there. So definitely when you consult a right person and you get a good treatment options, this cost of and the quality of life can be improved in neurological conditions. So this awareness need to be there, and we would like to have such initiative where we can spread the awareness about the neurological disorders, the brain tumor, the trauma, the spine disorders, which are actually the burden to the society by reducing the quality of work they are doing.
Dr. Deepak, would you want to
leave us with any
concluding remarks? Yes.
No. Thanks. Thank you so much, Rajashree, for providing us this opportunity. It's been a wonderful time and it was wonderful discussing our topic of our interest. I hope this creates more awareness in our patients and caregivers, and they have a better approach towards Parkinson's disease.
And I would again conclude with the same thing which I say, that by adopting an integrative and personalized approach that encompasses medical management, surgical procedures, nutrition counseling, physical activity, mindfulness, complementary therapies, putting all that together, we are going to do great to the society at large. So I think we all are together in this, and thank you very much, both of you again. And thank you very much, viewers. You've been supporting us for past 4 or 5 years that we've been actually doing these online programs, and we will continue to bring such interesting and educational topics over and over again. With that, I think we'll conclude
Yes.
the session, and I'm just going to quickly share a short video of Energia because they keep supporting us on our programs. The team supports us on all the back end to do this. Ash, are you planning to share a screen at the back end? Okay, we'll conclude it here because I think I am having some technical issues in playing the video. But thank you again, all of you.
Thank you so much, Raj.